It's Dr. VanDyke, and I want to talk to you about the basics of heart health, heart disease, cholesterol. And this is important because we will be launching another series of episodes that's devoted to the state of heart disease in our country and around the world and what patients should be doing about it. So this is kind of a primer to get ready for those episodes. First, I want to talk about some facts and fictions. Facts about heart disease. Number 1. Heart disease kills more people in the United States than all of the cancers. And we take cancers pretty seriously. There is actually one death by heart attack, and this is heart attacks only. One death per minute in this country, so that's well over 500,000 people per year. 50% of those people every minute will not survive long enough to get to an emergency room. For the patients who can get to an ER, modern cardiology is very good at prolonging life, with varying degrees of preserving the function of the heart in the long term. One thing that I want everybody to know is that 100% of us are born with atherosclerosis. That's those early heart plaques that everybody's so worried about when you turn 50. But it actually starts while we are in utero, before we're born. And the thing that upsets me the most about the fact that we have people having heart attacks every 60 seconds and half of them are dying before they get to an emergency room is that heart disease is almost entirely preventable and it is very, very treatable. And so in most cases, people should not be having heart attacks in this country. But we can only achieve this if we are paying attention and are appropriately aggressive early in life. In the obesity handout discussion, we reviewed that there are no differences in long-term weight loss outcomes among any of the different diets. So in that sense, choosing a diet only matters in terms of what fits into your life. What can you do every day? But that is not true with heart disease. The vegan and the Mediterranean diets are the only diets that are known to reduce mortality or death from cardiac causes. I want to repeat that. The vegan and Mediterranean diets are the only diets known to reduce death from heart disease. These diets are reasonably easy to integrate into a diabetes lifestyle. Let's talk about the process of plaque formation. The whole thing is mediated by inflammation. And in this country, in this day and age, we live extremely inflammatory lives. How do we do that? Well, we spend most of our time sitting. So that's why your doctor is nagging you all the time about, are you exercising? How long are you exercising? What are you doing? You should be running more, blah, blah, blah. That's because the inherent value of exercise is about mitigating or shutting down these inflammatory processes. We can actually see some plaques on x-rays and CAT scans that we do. And most of the time when we're looking at these things, we see them in the aorta, that big vessel down the center of your body. And that's because it's so large. But the older you get, the more plaques you have in there that are calcified, and they show up pretty bright on these images. But if you have a plaque in one spot, you are guaranteed to have plaques in many spots, but not all of them will show up on an x-ray or a CAT scan. I want to let you know that there are 2 huge risks for developing heart disease. The number 1 risk for developing heart disease is age. And it turns out that getting older is the number 1 risk for just about everything. The number 2 risk is being male. So guys who are getting up there in years are in a bad place if they are not paying attention. Now let's talk about some of the things about heart disease that are not true, but continue to be perpetuated by all kinds of publications, whether they are credentialed or not. And I want to talk about this in a way that patients present them to me when we're in the clinic. Number 1, patients say, I'm too young to worry about heart disease. Well, like we discussed, that's not true because we have plenty of evidence that show us that the plaques start before we're born. Number 2, patients say, my cholesterol has never been high, so I don't have to worry. It turns out that the average bad cholesterol, or LDL, of a patient having a heart attack in this country now is 90. And so if you're falling into an LDL less than 100, like the lab reference range says you should, that does not mean you are protected. Patients say, my good cholesterol, that's the HDL, is so high that it makes up for my bad cholesterol. Well, they're not wrong about that. HDL is in fact a good pipe cleaner, but that's only true if the molecule is active. And so far, we've had no way of measuring how functional HDL levels really are. So it's nice to have a high HDL, but we cannot count on it to save us when other things are high, like the LDL. Patients say, I won't take a statin because it causes diabetes. So they're not wrong. Statins have been found in the literature to accelerate the onset of diabetes. But this is happening in patients who are already pre-diabetic or at significant risk of becoming pre-diabetic. So once we have accounted for all of the variables in those scenarios, the difference in the onset of diabetes is only about 2 years. Patients say, I won't take a statin because statins cause dementia. Well, there was literature that said statins were linked to dementia. However, in 2013, a study by Johns Hopkins that reviewed many other studies examining over 23,000 patients found that this was not a causative relationship. Statins are, in fact, potent anti-inflammatory agents that will protect the vasculature in the long term and reduce the risk of dementia caused by vascular events. We all know people who have had TIAs, or these early strokes or little mini strokes. When those things happen, they cause damage to the tiny vessels in our brains. So if patients are treated appropriately on statins early in life, then their risk of more vascular events actually decreases. Patients will say, I can't tolerate taking statins. They cause so much muscle pain. Okay, so we have some evidence to show that that can happen. The blinded, randomized, placebo-controlled trials do show that there is no significant difference in the onset of muscle pain regardless of whether the person was taking the actual statin or a placebo. Remember, in blinded studies, patients don't know which pill they're getting. We do know also that even a small dose of a potent statin a few times a week can have an important impact on disease prevention. So in the few cases of patients who genuinely cannot tolerate statins, it's not reasonable to do it every day, but I do have a fair amount of success in getting patients to take even just 5 milligrams of Crestor once or twice a week. And most frequently, those patients are able to slowly and carefully get up to dosing every day without significant changes in their muscle pain. Patients will say, I am a very heavy exerciser. I run marathons, do triathlons, all that stuff. So my heart is fine. Even people who look amazingly healthy and fit and who can perform incredible athletic feats can still have heart disease. And this is probably due to a number of hereditary disorders of cholesterol metabolism. So just because you're fit and healthy and active and doing well does not absolve you from screening. Everybody deserves to be screened. Patients will say, my heart disease is genetic. What's the point? There's nothing I can do about it. Now that one is wrong. We have many tools, medications, and technology to identify early heart disease and regress atherosclerosis. And it turns out a number of these medications and strategies we use are generic. Number one, the cornerstone are the statin medications. These are the medications like Lipitor, Crestor, atorvastatin, rosuvastatin, simvastatin, pravastatin. Everybody seems to be familiar with at least one of those. There's a medication called Zetia or ezetimibe that also can work with a statin synergistically to further reduce cholesterol. For people who have extremely severe high cholesterol levels, and this is usually due to a rare familial trait called familial hypercholesterolemia, we have medications called PCSK9 inhibitors. And I won't go into the details of how those things work, but these are drugs like Repatha, and they are injections, but they're extremely potent, and they have been very successful at getting these patients toward their goals. Of course, there are always lifestyle and dietary guidelines that are useful in anybody who has high cholesterol or in primary prevention of heart disease. In terms of the technology we can utilize, we have certain cardiac imaging that is useful. The coronary artery calcium score can give us a window into the plaques that are in the tiny vessels in our hearts. And if we have positive scores, we deserve to be treated fairly aggressively. Blood tests are also important. Not only can we measure cholesterol, but sometimes we do a specialized cholesterol panel on people to analyze how big the particles of cholesterol are, and that can have important implications on your risk for a heart attack. We can also measure markers of inflammation, and we can identify disorders of certain genes that will affect cholesterol metabolism. So how does a patient know he or she is at risk? Here are the things that we care about. Number 1, has anybody in the family had a heart attack or a stroke, especially if it happened at an early age, like less than 55? Has your total or your bad LDL cholesterol ever been high? Do you have other diagnoses like prediabetes or diabetes, high blood pressure, rheumatoid arthritis, HIV, cancer, or kidney disease? Because all of these things, and many more, are very pro-inflammatory. Do you eat saturated fats? And the short answer is basically every one of us in this country does, because saturated fats are the meats, butters, lard, coconut oil, or any other fat that is actually solid at room temperature. That's how you can tell. Are you overweight or obese? Because smoking makes your blood sticky, and it promotes inflammatory processes in the body, which of course is going to deposit more plaque all over. Let's talk more about that coronary artery calcium score. This is a non-invasive CAT scan of just the heart. There is no dye or contrast, no IV is required, none of that is used. The imaging is synced to an EKG so it can get a good picture of your coronary vessels. The scan takes about 10 minutes, can cost anywhere from $50 to $150 depending on where you have it done. Some insurances cover it, but this is state dependent and it is payer dependent. I have identified 3 places in the Dallas Metroplex that do this. One of them charges $60 and the other are a little over $100. The radiologist and the computer calculate a standardized score of plaque formation in those tiny coronary vessels in the heart. And long-term data shows us that when a coronary artery calcium score is 0, the odds of a cardiac event are less than 1% in the next 5 years. So even if you're diabetic, if you have a coronary score of 0, you can make a strong argument that it's not yet time for a statin or aspirin. Any coronary score higher than 0, even if that number is 1, and regardless of age, does correlate with significantly higher odds of cardiac events over the next decade. The higher the score, the higher the odds of an event. Scores over 100 are a pretty bad deal, so those numbers deserve quite aggressive treatment. And medical therapy is very effective at minimizing bad cholesterol and reducing heart-related mortality. In fact, that is what effects the real change in patients who've already had a heart attack. Your cardiologist is the hero, right? Because he or she is able to fix the plumbing and put the stent in or do the bypass, but it's the medications, the statins, the Zetia, the PCSK9 inhibitors in the long term that remodel the plaques in the body and stabilize the ones that are at risk. So what if a patient's score is 0? Well, like we said, your risk of an event in the next 5 years is minimal. But we should check again in 5 years because remember, age is the number 1 factor for heart disease. What if a patient's score is small? It's just 1 to 10. Again, I will underscore that any number greater than 0 matters and deserves medical therapy for optimal outcomes. When you have more questions about heart disease and all of these things that we reviewed today, I want you to draw upon resources that are reliable, validated, and written in human-style English. So I would recommend checking out the National Heart, Lung, and Blood Institute. They're at www.nhlbi.nih.gov and at healthyeating.nhlbi.nih.gov. Of course, the Mayo Clinic is a great resource for everybody. Check out mayoclinic.org and the Centers for Disease Control at cdc.gov. The Heart Association also provides insights on a heart-healthy diet and cooking and recipes, so you can go to recipes.heart.org for more information.